Dr. Lisa Maier from National Jewish Health. She came here from Denver to be with us. Thank you, Lisa.
Thank you, Kelly. I want to thank the FSR for hosting these sessions. I've been fortunate enough to have been working with them for a number of years, and they are really taking many of our missions to improve education and awareness of this highly misunderstood disease and really neglected disease to a new level. And so it's always, for me, a real joy to be able to come here to talk to you all. I also want to thank all of you for coming out today to talk with us, and to Dr. McGonigal for sharing her very heartbreaking story. So sorry. These are exactly the kinds of situations that we don't want to happen. We want to prevent. Unfortunately, there are pieces of the story that you just heard, as probably many of you know from your own stories, that really continue to be problematic as we, as physicians, and you, as patients and family members and teams supporting your loved ones within the medical community. And hopefully these kinds of events, this kind of educational process will help prevent some of those stories from continuing to happen. I always tell my patients, this is a partnership. I'm not here to tell you what to do. You're here to tell me what's going on with you. We're here to work together, and you have to be your best advocate, because none of us can be with you day to day as you go to see your primary care, as you go to see other physicians. And so I think that hopefully some of the information that you did hear from Dr. McGonigal's talk will be further echoed in some of the comments that I'm going to make, because there are pieces of what you've heard that I think we are trying to target, those of us who really focus on sarcoidosis care. And one of just a little nomenclature piece, so most of us that you're going to be hearing from today, except for Dr. Rosenbach, who's a dermatologist, also are pulmonologists. But we also consider ourselves sarcoidologists. And so I think that that's something that's important for you to think about. There are people who take care of all kinds of pulmonary diseases, and not that I don't see people with asthma and COPD and other lung diseases, but my focus isn't just on the lungs in those diseases. As a sarcoidologist, my focus is on the patient and all the problems that they're having. Obviously, I'm not a cardiologist. I'm certainly not a dermatologist or a neurologist, but this is a team-based approach from a physician standpoint, and it really needs to include people who have expertise in some of those areas. And not all of us have expertise in all areas, and that's an area that again, I think that you need to work with your physicians in that regard. So just to briefly outline what I'm going to talk about today, and please, if, depending on how much time we have, if there's something I'm saying that doesn't make sense, we can try to stop. But again, I want to keep us on track, because I know the other folks are going to be coming and going to the other conference, and we're going to all come back to the panel at the end. So I'm going to talk about disease definition. How do we define what sarcoidosis is? What is the clinical presentation? Again, you just heard, it's not just the lung. We call it a differential diagnosis. So when somebody says sarcoidosis, or when we see some of these findings, whether it's on the CAT scan, the chest X-ray, the symptoms, or on even a biopsy, what do we as doctors think about? And what should people be excluding? We're going to talk a little bit about the imaging, radiographic imaging that people do have. What, again, would be my recommendations kind of as an initial evaluation, some follow-up, and then talk about how do we get biopsies, how should we be getting biopsies, and I'm going to touch briefly on some what we call biomarkers. What's a biomarker? Well, biobiology. It's just something from the patient that we can use to mark the disease and potentially follow it. And prognosis. What's going to happen to me? Right now, we have not done really well with that last one, that prognosis piece. But it's something that many of us really are trying to invest a lot of time and effort into understanding better. And you're going to hear more about a lot of these pieces in more depth as we move forward. I think there's some pitfalls and challenges to the diagnosis of sarcoidosis, and you've already just heard one. It's a diagnosis of exclusion. What does that mean? Well, what it means is there are a lot of other diseases that can look just like sarcoidosis. And if we don't really make sure we've got the right diagnosis, then we're not going to treat people correctly. And that, as a result, sometimes it can be hard for people to establish this diagnosis. I've seen it on both extremes. One where a patient comes to me, they've clearly had what I would have called sarcoidosis. The doctor's actually done a pretty good job of excluding other diseases, but they've never been given that diagnosis. Well, that doesn't allow them to be their own advocate because they don't know what they have. It may not have allowed them to be followed as well as they should have. And certainly, they've got a sense of uneasiness. I've seen the other situation where somebody was diagnosed with sarcoidosis. It was something else. It was a disease that an exposure caused, and if we could have gotten them out of that exposure, their disease might have been actually better than it was the time I saw them. So I think it's important to think about this on this entire spectrum. We have to continuously reassess the diagnosis, and I think, again, the story, the heart-wrenching story you just heard, is exactly the reason we have to reassess the diagnosis. And I don't mean that we recheck whether this is sarcoidosis or not at every visit, but as physicians, your doctors and you should be continuing to rethink what symptoms you are having and whether they're changing and what the test results that they're getting are showing them. It's not just, you've got sarcoidosis, here's what we get, here's what we do for treatment, go on your merry way. This disease changes, and we need to make sure that we're thinking about how it's changing so that we can make sure that, as a group, people are being treated appropriately. There are some issues that some organs are more difficult to diagnose, or organ involvement. And the tough ones are cardiac disease and neurologic disease. Why? Well, they're kind of hidden organs. You know, I can get an X-ray in my lung pretty well with pretty conventional testing. For cardiac testing, there's special tests that have to be done. Biopsies are really hard to obtain of the heart. Biopsies of the lung are pretty easy to obtain. Biopsies of the brain, we all get nervous with that. So that's where there are some more specific difficulties, and I think really bringing more and more people who have expertise in sarcoidosis, in those specific organs, to the table is where we're going to continue to advance this disease. And again, the FSR has actually got a listing of some of those specialists in those specific organs. And Dr. Rosenbach is going to talk to you again about one of the organs, the skin. There's something else that doctors have called parasarcoidosis. What's parasarcoidosis? Well, para just means next to. Paralegal, right? Works with somebody who's an attorney. And a parasarcoidosis is something that we don't exactly know why it develops. It's not the disease itself, or these clusters of white cells that I'm going to talk about that are called granulomas, but it is other aspects of the disease that seems to create those. And you'll hear a little bit more about that. Some of this pain that a lot of people get, the small fiber neuropathy, that's parasarcoidosis. And that one is hard to diagnose, especially in people who don't have sarcoidosis or who aren't seeing a doctor who's familiar with it. And that's where a pulmonologist without expertise in sarcoidosis, when a patient goes to him and says, no, my lungs are fine, but gosh, my legs are hurting me. I can't sleep at night because when the sheets brush them, they hurt incredibly. That's where sometimes those doctors don't recognize some of these other problems. And then finally, sarcoidosis has been called the great masquerader. If any of you have watched House before, every single show, sarcoidosis came up on the list. So that's again where there's pitfalls and challenges with this disease. So here's a definition that comes from a professional society. A compatible means it's consistent, it looks like, clinical and radiographic picture. Okay, so here are these clusters of white cells, those granulomas there that we talked about. and a chest x-ray that looks like it's sarcoidosis, and excluding other diseases. So that's a formal definition, and I'd say most of us really use that. There's a couple of exceptions. One of them is if you end up with this one variant of this disease, this kind of acute form called Lofgren syndrome, where people end up with fevers and chills, night sweats. They do get joint involvement. They do get these nodules under the skin and lymph nodes in the chest, and that's called Lofgren syndrome. And biopsy's not needed. There's nothing else that does that. But otherwise, really, a biopsy is usually required. And that part of that is to make sure that we're not missing an infection, because that is part of the differential diagnosis. I'm not expecting you all to read this, but what I want you to take away are some of the big categories. Occupational exposures can cause a disease just like sarcoidosis. We actually reported on a cluster of cases in a community not too far from here in Reading, Pennsylvania. And then there's other biologic exposures that can cause it. There are autoimmune diseases, connective tissue diseases, not rheumatoid arthritis per se, but some that are similar that can look like it. Infection, I've listed as a big one. And then the C word. Every patient, I have to tell you, that I have seen has come to me and said, they told me I had cancer. And I had to, one of my patients was Christmas Eve, he was told that. And he had to wait to get his biopsy and then to find out for sure. And gosh, if we could figure out a way that people didn't have to go through some of the waits that they do to get the disease diagnosed, that would be great. But there's been a recent study to actually suggest that it can take years in some people to get the diagnosis. Part of the problem with this disease that we've already alluded to, and again that you've already heard from our first speaker today, is that this disease can affect every organ in the body. Now, in most people, it doesn't. 90-some% of people, 90-some% of people will have lung involvement. And that's why most of us who take care of people with sarcoidosis are pulmonologists. The other organs that can be involved vary. Some big ones that we do worry about: eyes, heart, neurologic, aren't as common, but can again cause significant problems. Skin is pretty common, and that's probably about a quarter of people. There are some differences. The graph on the other side just is to show you there are differences in whether you're black or you're white, and how the disease is likely to manifest or present. So again, we know in people that are black, they're more likely to have skin involvement, liver involvement, eye involvement. There is some data that Caucasians may have a greater risk of having heart involvement, and men may be a little bit greater than women. Because in general, what we know is that women have a little bit more of a risk for this disease than men. And you'll also see that there's might be a little bit of a difference in age, too. If you're younger versus if you're older. Lymph nodes is the main thing. But the point that I want to really hit home here is that this disease can present with somebody just who's got cough and shortness of breath. Again, you heard two different cases before. Or it can present with someone who may have significant palpitations. And so isolated disease, so isolated cardiac symptoms or isolated nervous system symptoms can be more problematic to really figure out if that is sarcoidosis or not. The symptoms related to this disease really, as I just mentioned, are varied. For the lung, it's no different than what we would see with someone who has asthma or COPD. It can be cough, shortness of breath, problems when they exercise. Others would be kind of more other general symptoms, can be the fevers and night sweats that you've heard about. Fatigue, we know, is a really significant symptom in this disease and really is quite devastating from the standpoint of people's ability to live their regular lives. But pain, rash, joint muscle aches, vision difficulties, but these are just a few of the symptoms. And so when my patients come in for an evaluation, we have them answer a whole laundry list of questions. And when they come back, they answer that whole laundry list of questions. And I know sometimes they think, you asked me this last time. Well, I did, but I want to make sure it hasn't changed. And that's where, again, the other piece is when we know that somebody has organ involvement, we really try to focus up on some of those symptoms more. So one of our approaches to this disease is really indicated by the lungs, but it's an approach that most of us try to use for every organ. And that is, we try to assess how bad is the involvement. So people can have, in this disease, they can have pretty abnormal looking chest X-rays. They can sometimes have symptoms, but the function of whatever the organ is that's involved, whether it's the lung or the eye, or even sometimes the heart, may not be as bad as we think. So we try to get some quantitative, some numbers to let us know how bad is bad. One of the big focuses is the lungs because, again, 90-some% of people have lung involvement, and many of those people do have abnormalities. And quite honestly, the biggest cause of death from sarcoidosis in this country is from lung disease. Most people die with sarcoidosis, not of it. Many people's quality of life is severely impaired, and that's a big issue. But that is part of the reason that the lungs are such an important focus. And so we do breathing tests, and this is just an example on the upper corner here, someone going through those breathing tests. I'm sure many of you have had those. And not everybody needs them as frequently as others. Some of it depends on how active the lungs are. But many of us like to see some of those lung function numbers on a yearly or every other year basis, depending again on how active the disease is, if not more frequently. Sometimes people can have an asthma-like presentation. They have more trouble getting air out. That's called obstructive. Sometimes people have, and their lungs are shrunken or scarred down, and that's called restricted. Sometimes people have problems with their oxygen levels, and they have to wear oxygen, especially with insertion. Sometimes they have all of the above. And this is, again, just an example of an assessment for one organ that we know is most commonly involved. We do chest radiography. Chest X-rays have been used a lot to follow this disease. And the reason I bring this up is people always say, what stage am I? And I want to make sure people understand. Scatting staging is just a kind of a scale that's been used in sarcoidosis for many, many years. It gives us a rough idea of how much involvement there is. Stage 0, normal. Stage 1, just the lymph nodes are abnormal. That's the parts right here in the chest. Stage 2, we've got the lymph nodes and the lungs. Stage 3, I didn't have room for. No lymph node involvement, but the lungs are abnormal. Stage 4, the lungs are getting scarred down, smaller. Now the problem is that this isn't a perfect or a continuous staging scale. This is not like when people hear, oh, I'm stage 4 for cancer. It doesn't tell us the same kind of information. People don't move from stage 0 to 1 to 2 to 3 to 4, etc. Sometimes people go from stage 0 to stage 3. Sometimes they come back to have a more normal X-ray. Sometimes they stay at a certain stage and their disease can still get worse. It gives us some very kind of big ideas of what might happen, but not always from a lung standpoint. So if you've got kind of early disease, stage 0, 1, even some stage 2, a lot of those people do get better. The disease goes away. Stage 4, it usually doesn't ever go away. But again, it's not a great tool for us to say how a patient's going to do. And as a result, a lot of times people do use CT or chest CAT scan to follow the lung disease. And again, this is just to show you, just as I said, the symptoms in sarcoidosis can vary, the organs that can be involved in sarcoidosis can vary, so do the CT scan findings. And again, not always do the abnormalities give us a good idea of how bad the lungs are doing. Sometimes they do. And so that's where really a lot of people have been hearing in the news about something called personalized medicine. Have you guys heard about that? Yes. That we should be trying to target whatever disease it is to the person, not to just have these overall approaches. in my mind, sarcoidosis is the poster child for personalized medicine, just because the disease presents differently in each person, and each person we really need to come up with a personalized plan. You heard a bit about a cardiac PET, and I wasn't going to talk as much about that, but I made just for a couple of minutes, but I did bring up an FDG PET scan. So this is a study that measures cells that are dividing, or what we call metabolically active. They're taking up glucose. And it's been used a lot for cancer. It doesn't give us a diagnosis of sarcoidosis per se, but sometimes it can be useful to sort out where the disease is. And so, for example, in this patient, you can see these yellow spots. So they're significant around where the lymph nodes are in the chest, the liver, and the spleen. That actually goes along with this patient's history. It can help us if we can't figure out where to biopsy for somebody. It gives us some ideas of some other organs that can be involved. The issue with some of the testing for the cardiac MRI or cardiac PET, those have to be done places where they know what they're doing. They've got cardiac preps for them, especially for the PET scan. You can't just have this regular FDG PET to look for cardiac involvement, because the heart will light up at times when it's really not involved. And a lot of places don't do those, even have the software to look for the cardiac abnormalities on MRI, or know how to have the PET scan. And I actually had a 28-year-old come to me because she had a PET scan at a major medical center. They didn't do the right prep. Her scan looked abnormal. Luckily for her, we really don't think she has it from everything else that's been going on. She didn't have any symptoms either. And it just shows you that we still have a lot to learn about how to use some of these tests. And so using them in everybody isn't necessarily the best thing, but using them in the right people is definitely what we need to be doing. So I talked about biopsy confirmation, and you've heard about someone having a surgical procedure and needing stenoscopy. Most people today should be able to be diagnosed with this disease without having a major surgery. We have a lot of non-surgical outpatient procedures that can be used, and a bronchoscopy, which again is another reason a lot of pulmonologists get involved, is actually the best and easiest way. And there's a couple of different things. The airways can be involved. They can get small biopsies from the airway about the size of the end of a pencil tip. They can do this ultrasound-guided biopsy, or they can just get some random biopsies within the lung. And usually, that will give us the diagnosis. Dr. Rosenbach can talk to us about using the skin as a very accessible place to get a diagnosis, as long as you have evidence of disease somewhere else. And again, occasionally we really do have to use something like the PET scan or go after some other rare places to try to get the biopsy. But again, what we're looking for are these clusters of white cells called granulomas. So, what is the future of sarcoidosis disease? I just already mentioned this. It's this personalized medicine, and hopefully what it can help us to do is to improve our diagnosis of this disease, as well as our follow-up of patient. Maybe it'll help us streamline. Gosh, wouldn't it be great if you could go in and have a blood test drawn and someone tell you, yes, you've got sarcoidosis, and yes, it's active. Or, you know, you've got sarcoidosis, it's not active, but I'm worried you could have cardiac disease that might pop up in 5 or 10 years. So I kind of think of it as who, how, and what will get worse or better would be our ideal. And there are some preliminary studies that people are conducting to look at differences in some of the genes and how they're showing themselves in the body over time. And that's what actually this big graph shows, is when Dr. Laura Koff from UCSF followed this group, she found that if they had these certain markers, these biomarkers I mentioned, that the people who got worse were more likely to have this one pathway over time. I'm not going to go over all of this. This is kind of our general workup for sarcoidosis. When I see a patient, I do a physical exam, I look for all of these different abnormalities, the parotid glands, which are here, salivary glands. I look for in the nose to make sure that there's a septum, etc. And then we check a number of blood tests when we first see the patient. We send everybody for an ophthalmologic evaluation because, again, you do not want to lose your eyes to this disease. We want to catch that real early. And then we usually will reassess some of these tests on a yearly basis as we see people back, and others depending on the symptoms. We definitely do an EKG, and we often do echocardiograms, and we ask a lot of questions about heart symptoms, and if there are any that are there, that's when we say it's time to undertake a visual evaluation. So, just to bring things to a close, not all of these clusters of white cells are granulomas or sarcoidosis. There are other diseases, and that's where sometimes I think physicians get lost. We do have to look for other organ involvement than just the lung. This is a team-based approach. We have to continuously reassess the organ involvement or the disease presentation. It does change. Just because you got organ A and B right now doesn't mean that 5 years from now those are going to be the only two involved, or that they're still going to be involved. And again, the thing that I think a lot of my patients struggle with is not all symptoms are due to their sarcoidosis, but not all of their symptoms are due to other diseases either. And that's where this balance and this ongoing conversation with your coach or your primary person, as Dr. McDonald already mentioned, really is a key point to managing this disease ongoing. Are there more questions?
More questions, yeah.
Thank you for allowing me to talk to you.